Good morning, everyone. So we'll change gears a little bit now and talk about type 2 diabetes and kidney dysfunction, how to prevent heart failure. It's a bit embarrassing because I have David Cherney here, who's really one of the world leaders in kidney dysfunction, so hopefully he doesn't heckle me too much during this talk. So what I thought we would do over the next little while is, I should put my disclosures up. I will be discussing some drugs, and I am 100% conflicted. I've worked with virtually every major company in this area, but the most important disclosure is that I'm an Australian and my relatives were kicked out of England because we were thieves. I also hold some patents in the heart failure realm. So the objectives today are really to talk about type 2 diabetes and renal dysfunction and give you a bit of an overview, not just renal disease, but how heart failure and renal disease interact in the patient with type 2 diabetes. I'm really not going to present any data on type 1 diabetes, so if you have any questions, we can discuss that later or offline. To really talk about markers for the development of diabetic nephropathy, and then talk about some recent data with the newer anti-hyperglycemic agents, the SGLT2 inhibitors and the GLP-1 receptors, about how they can impact renal outcomes and heart failure outcomes. And there's a new trial called the Credence trial which came out. I won't be talking about that because I'm leaving that for David to go over in more detail. So this is obviously the sort of slide that's supposed to scare everyone. We really do have a major problem in Canada at the moment, just like the rest of the world does. So we have around 3 million people with diabetes. We have about 7 million people with pre-diabetes, and the majority of people with pre-diabetes will go on to develop type 2 diabetes. So at the moment, diabetes accounts for 1/3 of all heart attacks and strokes, 40% of all heart failure admissions, 2/3 of all non-traumatic amputations, and half of all patients starting dialysis. And the majority of patients who have type 2 diabetes die a cardiovascular related death. That's about 75 to 80%. So if you ask most patients, they're usually concerned about eye disease and kidney disease, and not to belittle eye disease and kidney disease, these are important issues, but it's usually a cardiovascular death you die of. And in fact, at the moment, 1 in 10 deaths in Canada is a direct result of a complication of diabetes. And you can see with those numbers, we're now looking at almost 25% of the population have diabetes or pre-diabetes. And unfortunately, it's only likely to get worse over time until we can counteract, I think, the obesity epidemic. And of course, if we look at one of the commonest presentations of type 2 diabetes, it's kidney disease. And here you can see, if you really look at what are the 4 big presenters here, you'll see lower limb amputations, end-stage renal disease, chronic kidney disease, and heart failure. They're really the most likely things that patients are going to present to the hospital for when you have a diagnosis of type 2 diabetes. And this is manifest here if we look at, well, what are the most important causes of end-stage renal disease. You can see the dashed line up the top there. You can see, look, that's really type 2 diabetes, and diabetes is the major driver of end-stage renal disease. And if you develop end-stage renal disease, what usually happens? The majority of those patients actually die a cardiovascular related death. And a lot of those deaths are either stroke, heart failure related deaths, or myocardial infarction and ischemic related deaths. So you can see this sort of story of interrelation between diabetes, kidney disease, and heart disease, and I'll give more data as we move forward. This was a nice paper a number of years ago just to demonstrate very clearly that if you look at the GFR down there, you'll see greater than 60, then we go through the various stages of reduction in glomerular filtration rate, what happens to your rate of cardiovascular events. And you can see as the GFR goes from 60 down to 15, there's a dramatic increase in cardiovascular events. And this was both diabetic and non-diabetic population. This was a US database. But I put this one in as well to also show, because I've just told you diabetes is bad, and I've told you kidney disease is bad for driving adverse cardiovascular events. And if you look there, if you look at the all-cause mortality, you'll see if you look at diabetes and you look at the standardized cumulative incidence, obviously diabetes is a big driver of adverse events. If you look at kidney disease, not necessarily diabetes kidney disease, it's a big driver of adverse cardiac events. And then if you combine the two, you get this additive effect. So the combination of diabetes and kidney disease is absolutely dynamite for driving adverse outcomes. So anything we can do to prevent that will prevent adverse events there. And you can see that those trends actually are consistent whether or not you look at all-cause mortality, cardiovascular mortality, or just non-cardiovascular mortality. So there's something about the two that interact that are big drivers for terrible events for our patients. Now, one of the very sort of simple ways to move forward in a practical way is how can we identify those patients that seem to be at really high risk? I've told you GFR is a very good marker. Less than 60, you can see that dramatic increase in the risk of adverse cardiovascular events. But another very simple marker is the urinary albumin-creatinine ratio, which we all do routinely in our patients with type 2 diabetes. And this was taken from an analysis of the SAVOR trial, which looked at saxagliptin in patients with type 2 diabetes. The overall trial was neutral, but Ben Sirica then looked at, well, as the urinary ACR increased from less than 1 to 1.1 to 3.3, 3.4 to 34 and greater than 34, and you can see that it's a very good predictor of myocardial infarction, hospitalisation for heart failure, and indeed Herzl-Gerstein and the group in McMaster looked at this in HOPE trial, which we all would have used ramipril extensively for patients with type 2 diabetes and showed a similar effect. So we do have simple biomarkers that are available that are very good at identifying those at highest risk, and you'll see that that risk really increases at very low levels of the urinary ACR ratio. 2, 3, 4, it's abnormal, but it's certainly not off the charts. And as I said, this is a practical marker because we can do this. One of the issues you heard about BNP before, BNP is very good, but a lot of people can't access it and there's a cost associated with it. So urinary ACR we can do without necessarily incurring a cost to our patients. So what do we use to diagnose chronic kidney disease in our patients with diabetes? So this is from the 2018 Clinical Practice Guideline update from Diabetes Canada. So chronic kidney disease in diabetes is defined as an ACR greater than 2, so small rise, but that's CKD, and or an estimated glomerular filtration rate less than 60 mils per minute per metre squared. So if you have one or the other, you now have chronic kidney disease, and I've already showed you that once the EGFR is low and the urinary ACR is high, you're at a particularly high risk of going on to progress to end-stage renal disease and the cardiovascular, adverse cardiovascular events. And just to remind us all, I've sort of mentioned EGFR a number of times. We do use this staging system. I'm sure you're all familiar with it, with greater than 90 being so-called normal GFR, stage 2, 60 to 89. We divide stage 3 to A and B, 45 to 59 and 30 to 44. And then we have severe reductions in GFR, 15 to 29. And stage 5 is end-stage renal disease, typically defined as less than 15 there. Now, for our patients with diabetes, how do we estimate those at high risk? Which are those patients that really we want to say, okay, we really need to aggressively treat to try and reduce that risk of developing end-stage renal disease and the cardiovascular complications? And then this is again taken from the Clinical Practice Guidelines update. This is Canadian data here to look at, well, how you can then look at what the GFR is and look at what the urinary ACR ratio is. And you can see if your ACR is less than 3 milligrams per millimole and your GFR is greater than 90, well then you get a green, you're at lower risk. But as you start to increase, you get a reduction in GFR and you increase the amount of protein that's excreted, you can see that they're at very high risk. And this identifies those patients that we may want to much more aggressively treat in terms of glycemic control, blood pressure control, or refer on to a nephrologist. And practically speaking, what I usually say is when the GFR is less than 60, or if the urinary albumin-creatinine ratio is greater than 30, that's really starting to identify that group that are much more likely to progress. So they're the ones I really get worried about, and contact your friendly neighbourhood nephrologist and make certain we really aggressively treat all the risk factors. Now again, back to the CKD and heart failure, you can see here, and this is a plot of EGFR, and as we go from 15 up to the normal range, out to a much higher range, you can see that the adjusted hazard ratio for heart failure increases as the GFR gets lower. It sort of normalises as we get back to the normal range. But as we get into this group of hyperfilterers, again, we see with GFRs greater than 120, we start to see a rise in the incidence of heart failure. So there is a sweet spot around that 90, and that's really what we want to aim to protect and prevent patients from developing then end-stage kidney disease and the complications. And you'll see here that once you've got chronic kidney disease, in the sort of pie chart on the left there, you'll see that heart failure is common in about 43% of all that group. So it's a very common association once you've developed chronic kidney disease. And in fact, it's such a big issue that a group has got together to come and classify this schema now to look at cardio-renal interactions. So you'll see here there's sort of type 1, type 2, type 3, type 4, type 5. And in type 1 and 2, it talks about acute cardio-renal syndrome. So the heart gets into trouble and it impacts the kidney in an acute setting, type 1. If it's in the chronic setting, we call that type 2. And then we flip it around for type 3 and 4, where there's been an acute kidney injury, and that then impacts the heart. That's type 3, or chronic kidney injury impacts the heart, type 4. And then we talk about the secondary cardio-renal syndromes, type 5. And that would be typical of, say, diabetes or a systemic disease like lupus erythematosus there. And the reason this schema came out, it was recognised it's such an important interaction, but we don't have a lot of treatments to actually identify if you do have acute cardio-renal syndrome or acute renocardiac syndrome. Well, what biomarkers should we do? Are there any specific treatments? We don't know that. So this was to try and classify patients in that area and help drive research so that we can come up with strategies to prevent the terrible outcomes that you heard about that Mike mentioned before from the heart failure setting, and then the terrible outcomes that I've told you from the renal failure setting once it's developed. Now, why also do the two interrelate? Well, if we look here, you'll see that when you have diabetes, there's very similar mechanisms and pathways that are activated that impact both the heart and kidney simultaneously, and then they impact each other, be it salt retention, excessive water in the body, renin-angiotensin system activation, inflammation, altered energetics. The two both interact on each other. So we have a good sort of sense why when the kidney fail, the heart fail, and vice versa there. And again, I think this scheme is useful because it starts to identify, well, these are potential therapies where one impacts the other. So if you protect the kidney, you're probably going to protect the heart and vice versa. So what can we now do to actually try and protect and prevent heart failure and kidney failure simultaneously? Because I think we don't want to necessarily break the two apart. The two go hand in hand. We want to think about what can we do to actually impact both simultaneously. So what we have so far, well, this is obviously one of the key strategies in our patients with type 2 diabetes is we know getting glucose down does protect against microvascular complications. In the type 1 patients, it's with insulin. In type 2, this is data from the ADVANCE trial, which looked at the combination of either perindopril or using a sulfonylurea to improve glucose, and you could see there that there was a significant reduction in neural worsening, nephropathy and retinopathy. So clearly, tight glycemic control, very important to reduce the complications, the kidney complications here, okay? And you can see there that the p-value is highly significant. What else can we do? Well, blockade of the renin-angiotensin system here. And this is just one slide here looking at the angiotensin receptor blocker. And you can see here that losartan reduced the primary endpoint, which is the time to doubling of serum creatinine, with a 16% risk reduction. And this then is one of the key bases why in our patients with type 2 diabetes, tight glycemic control and use of blockers of the renin-angiotensin system in those who have hypertension or elevated urea albumin creatinine ratios or a reduction in GFR to try and prevent the progression of kidney disease. And we know then that if you can use a renin-angiotensin system blocker, that you can then change the natural history, and actually you'll see in this graph here on the right that as you treat it and you reduce the albuminuria, you can see that there's a reduction in heart failure. So you protect the kidney and you protect the heart. And this is again one of the main reasons why we like these agents as cardiologists and nephrologists. Now, you saw this before. Probably the biggest change has been the impact of the class of agents known as SGLT2 inhibitors. I'm not going to go into a lot of detail, but just to show you similarities. So as Mike mentioned before, The first one came out was with empagliflozin or Jardiance, and we know that this demonstrated a reduction in patients who had established cardiovascular disease, so this was all secondary prevention, that the addition of empagliflozin reduced MACE events, cardiovascular death, non-fatal MI, non-fatal stroke, but we also saw that reduction in hospitalisation for heart failure. Now, if we look at the exploratory kidney endpoint, using what I describe as hard kidney outcomes, a doubling of serum creatinine, initiation of renal replacement therapy or death due to renal disease, we can see that we saw a reduction in heart failure and a 46% reduction in that hard renal endpoint. So again, protecting the kidney, protected the heart, and vice versa. This was with the EMPA-REG. Then the CANVAS trial came out, which was with canagliflozin or Invokana. Different trial in that there were approximately 66% of the patients had established disease, and about a third had multiple risk factors but without established disease. We saw that it was superior for the MACE, and again we saw a reduction in hospitalisation for heart failure. And if we look at the kidney outcomes again, you'll see that there was a 40% reduction. So different agent, but similar trend in terms of this kidney heart protection. And if we look at the more recent data that was just presented with the DECLARE trial with dapagliflozin, different again in this time, there were 60% with multiple risk factors versus 40% of the population with established disease. You can see then it didn't reach the MACE endpoint, but it certainly was superior when we looked at cardiovascular death and hospitalisation for heart failure, reduced that. And again, we saw a statistically significant reduction as an exploratory endpoint in the renal composite endpoint here. So there's a common theme here that the SGLT2s improve hospitalisation for heart failure and the renal endpoints there. And this is a way just to sort of look at the hospitalisation heart failure outcomes by renal function there. When we look at the trials with DECLARE, with an EGFR less than 60, and you'll see that the composite there, the little triangle underneath that, there was a 40% reduction. If we look at those that had an EGFR from 60 to 90, you'll see that again, there's a 31% reduction. And if we look at those who have an EGFR greater than 90, the benefit wasn't quite as marked, but of course that particular group is less likely to go on to develop heart failure. So you can see there's very consistent outcomes across all these agents. As the renal function gets worse, you get more protection and prevent hospitalisation for heart failure. Now, it would not do the literature justice to not mention the other hot topic in the area, which is the glucagon-like peptide receptor agonist, the GLP-1 receptor agonist, and that was the leader trial in SUSTAIN-6. And really what I want to point out with this busy slide to say that there's different effects as you go from the different anti-hypoglycemic agents. If you looked at the GLP-1s, there was a reduction in new or worsening nephropathy with the GLP-1 receptor agonists, so semaglutide and liraglutide, but this was primarily driven by a change in the progression of micro to macroalbuminuria. We did not see that same composite reduction in 40 or 50% reduction in EGFR, renal replacement therapy or renal death. And interestingly, if we look at the heart failure outcomes, they weren't nearly as strong with this trials as well. So the SGLT2 clearly seemed to improve heart failure, hospitalisation and renal outcomes. The GLP-1s reduced the progression for worsening nephropathy, but we did not see the same strong signal. So different effects with the different agents. So second last slide, when do we, with all that information, when do you say, okay, now I'm really getting worried about my patient. I've tried to improve their glycemic control. You've considered an SGLT2 and you've thought to do it or not. You've optimized their blood pressure. You have them on a blocker of the renin-angiotensin system. When do you say, okay, I really need Dr. Cherney's help? Well, clearly, if the EGFR continues to decline, this is telling you this patient's going to progress. We want to see what else we can do, and there may be new therapies. If the urinary ACR is persistently greater than 60, this is again a group of patients really rapid progressing. That's a problem. If the EGFR drops below 30, this is important because a lot of those therapies I just mentioned, SGLT2 inhibitors, they're not really indicated with an EGFR less than 30, so you're a bit stuck in what therapies we have, and I think that's when we want extra help. If you commence the patients on an agent like an SGLT2, for instance, and they have a dramatic increase in the potassium or serum creatinine, well, then that's a worry as well, and it's the same concern that if they had that big increase on a blocker of the renin-angiotensin system, because again, that says, okay, we've got a problem. We don't really have effective therapies now. What else should we do? And I think that's a reason to refer. And also if you have a lot of troubles with achieving the blood pressure target. So hopefully in conclusion, I've convinced you that heart failure and chronic kidney disease are really interrelated. One drives the other. I don't think we should be thinking of them separately. That glycemic controls, RAS blockade, have modest effects on heart failure and chronic kidney disease outcomes, but they still are the keystone and cornerstone of management, and that we now have newer agents with the SGLT2 inhibitors that demonstrate potent benefits on both heart failure and kidney outcomes, and that the GLP-1s demonstrate modest renal protection and overall relatively neutral for heart failure. So we are seeing differential effects within the class. But the important thing is that we have many new trials coming that are assessing both renal and heart failure outcomes. So this is going to be very exciting. The last comment I should make is the data that I presented was really about prevention. These weren't heart failure trials specifically. What is coming is actually looking at, do these newer agents actually work as bona fide heart failure drugs? So that's going to report out over the next 3 to 4 years. So there's going to be a lot more data at meetings like this to help guide what we should be doing for those patients. So with that, I'll stop and thank you for your attention.